Welcome to Test Day Panic. This is your lightning-fast, highly concentrated review. We're hitting the absolute must-knows for your exam.
No time to waste. Let's jump right in.
Okay, perfusion fundamentals. Where do we start?
All right, first thing, coronary arteries. These feed the heart muscle itself. Big point here, they only get perfused with oxygenated blood during diastole, when the heart rests.
So the heart feeds itself while resting. Makes sense. Then the mechanics. Compliance.
That's how easily the heart opens up, how well it accepts blood.
And contractility.
That's the squeeze, how well the muscle pushes that blood out.
Okay, clinically, you're listening to the heart. Always get a baseline for murmurs, right?
Yeah, absolutely. But, and this is key, a new murmur that must be reported to the provider, especially if you see signs of fluid overload along with it.
Got it. New murmur equals immediate report. Now, oxygen levels. Ischemia versus necrosis.
Okay, ischemia, think not enough oxygen. It's painful, yeah, but it's potentially reversible if you catch it.
And necrosis.
That's when the lack of oxygen goes on too long. Tissue death? Irreversible.
So reversible versus irreversible damage. We also need to talk resistance.
Right. Two main types you need to keep straight. Pulmonary vascular resistance, or PVR. That's the pressure the right ventricle fights against pushing blood to the lungs.
Okay, right ventricle, PVR, lungs, and the other.
Systemic vascular resistance, SVR, that's the big one. The huge pressure the left ventricle has to overcome to push blood out to the entire body.
Left ventricle, SVR, whole body.
Okay, so what happens when things go wrong? Labs, I assume.
Exactly. Your number one cardiac lab, troponin.
What's the deal with troponin?
It leaks out from dying cardiac tissue from ischemia. Baseline should be practically zero, like zero.
Okay, zero baseline, but I hear the trend is important.
Hugely important. Elevation can be delayed for hours, so one value isn't enough. You draw it repeatedly, monitor the changes, the delta. That tells you what's happening over time.
Right, the trend, not just the number. What about CCAM-B?
CCAM-B peaks about 12 hours after the damage, and it's mostly specific to heart muscle.
And things like myoglobin or creatine kinase. They show muscle damage, sure, but they're nonspecific. Could be skeletal muscle, could be cardiac. Not as helpful for pinpointing heart damage.
Don't forget BMP.
Ah, yes, B-natriuretic peptide. Really interesting one. The heart releases it under stress, like fluid overload. And it actually works to decrease blood pressure.
It was like the body's own diuretic or pressure reliever?
Kind of, yeah, a natural defense. The value you need to know should be less than 100.
Under 100, got it. And of course, check the CBC for blood counts and BMP for electrolytes, lipids. Usual suspects.
Always.
All right, moving to diagnostics. The cardiac stress test.
Okay, typically about 20 minutes. You can use exercise or meds if the patient can't exercise, constant EKG, and vital monitoring.
The critical part here is knowing when to stop. What are the absolute stop signs?
Okay, listen closely. You must stop the test if you see significant tachycardia. Any significant blood pressure changes, like if they get dizzy or lightheaded.
Okay, big heart rate or BP changes.
Cool.
That's all.
Significant shortness of breath, if their O2 saturation drops, absolutely ANY chest pain, or if any arrhythmias pop up on that EKG, stop immediately.
Any of those, stop the test. Clear. What about getting a better look inside? PE.
Transesophageal echocardiogram. Internal probe goes down the throat. Gives much better pictures because it bypasses the ribs.
Okay, better image. What's the prep? Sounds involved.
It is. Critical pre-procedure checklist. Patient needs to be NPO from midnight. You must establish IV access, verify informed consent is signed, get a baseline EKG, and crucially, check for dentures or any loose teeth.
NPO, IV, consent, EKG, teeth check.
Got it.
And afterwards, they've had sedation.
Right, conscious sedation. So post-procedure, you're watching vitals like a hawk, especially respiratory rate. They might need encouragement to breathe deeply.
Makes sense.
And teaching. Crucial patient teaching. Reintroduce food slowly. Their throat is numbed from the local anesthetic, so there's a risk of damage or aspiration if they eat too soon.
Okay, slow food reintroduction. Now the big one, cardiac angiogram, the cath.
Yeah, the arteriogram, or cath, uses contrast dye and X-ray to see narrowing or occlusion in the coronary arteries. High stakes.
Post-procedure care seems intense. What's the absolute must-do?
The patient must be kept flat. Absolutely flat. Prevents creasing or kinking at that insertion site.
Flat. Okay, and when the catheter comes out?
You hold pressure, firm pressure, until the bleeding stops. And remember, they've likely had heparin, so it can take a while. Then apply a pressure dressing.
Hold pressure till it stops. Got it. The most critical assessment after.
Limb perfusion. Check everything distal to the insertion site. Compare sides. You need to assess pulse, temperature, and color. Make sure that limb is getting blood flow.
Pulse, temp, color distal to the site. What if the insertion was in the groin? Any specific big warning sign?
Yes, and this is one you cannot miss. If they complain of unilateral back pain just on one side of their back, that is the biggest red flag for a retroperitoneal hemorrhage. Bleeding into the abdominal cavity. Major vessel might have been nicked.
Unilateral back pain after groin cath?
Yeah.
Think hemorrhage. Okay, let's switch gears to EKG rhythms.
All right, standard is the 12-lead EKG. Gives you that 360-degree view.
What if the tracing looks messy, all squiggly?
That's likely artifact, a false reading, usually from patient movement or loose leads. First step is troubleshoot check leads. Ask the patient to lie still.
Teach stillness. Got it. What does paroxysmal mean?
It means the rhythm visibly starts and then stops all on its own. You see it happen on the monitor.
Starts and stops. Okay. And a pause?
Just a minor irregularity, often hormonal, actually pretty common in women sometimes. Not usually a big concern unless frequent or prolonged.
And changes in the waves themselves, P wave versus QRS.
P wave changes point to an atrial abnormality. QRS changes point to a ventricular abnormality.
Atrial P, ventricular QRS.
Yeah.
Okay. Let's start slow. Bradycardia, less than 60 BPM.
Yep. Common causes. Think depressants, opioids, benzodiazepines, beta blockers, also anesthesia, or even hypoxia.
What's a first-line treatment?
Atropine. That's your go-to, first line. Give it IV push. Key thing, though, very short half-life. Its effect won't last long.
Atropine first, IV push, short-acting. What else?
If atropine isn't enough or wears off, you can use dopamine or epinephrine drips electrically. A pacemaker, especially if it's persistent or symptomatic.
Okay. Now faster. Sinus tachycardia.
For tachycardia, especially SVT, the first-line drug is adenosine. Think of it as a cardioverting medication. It chemically resets the heart.
Adenosine. Sounds serious.
It is. The heart literally stops for a second or two. You must have a provider right there and a crash cart ready. It has a super short half-life, like 10 seconds.
Wow, 10 seconds. How do you give it?
You need an IV as close to the heart as possible, like AC or higher. Push it fast, followed immediately by a fast saline flush. Push flush, really quick.
Close speed, push fast, flush fast. Got it. Other drugs for tachycardia.
Sure. Antiarrhythmics like amiodarone or lidocaine. They work by blocking electrolyte channels to stabilize the heart.
Okay. Amiodarone, lidocaine. Anything else?
Beta blockers and calcium channel blockers can slow the rate too, but be careful, they can cause heart block or drop the blood pressure too much.
So medication options. What about electricity for tachycardia?
If the patient is stable but needs intervention, you can use synchronized cardioversion. This requires sedation, consent. It's planned.
Synchronized. What's the critical point there?
The shock must be synchronized, timed precisely to hit the R wave. This is absolutely critical. You do not want to deliver the shock on the T wave. That's called R on T.
Why is R on T so bad?
Because shocking on the T wave can throw the patient into VTach ventricular tachycardia, a lethal rhythm. So sync to the R wave, avoid the T wave.
R wave sync is life or death. Got it. How is that different from defibrillation?
Defibrillation is the emergency shock. It's not synchronized. You use it immediately for lethal rhythms only, like VTach or VFib. When there's no pulse, it's a full reset, basically.
Synchronized cardioversion for stable tachy, defib for lethal rhythms.
Okay.
Let's move into atrial rhythms. Generally narrow QRS, right?
Typically, yes. Narrow complex QRS. First up, SVT supraventricular tachycardia. Rate usually over 160. It's so fast you often can't tell the P wave from the T wave.
SVT 160.
Basically the same as we just discussed for tachycardia, adenosine, other meds, cardioversion. Plus, you can try the Valsalva maneuver first, have the patient bear down like they're having a bowel movement.
Valsalva first, then the tachycardia treatments. Okay. Next, atrial fibrillation, AFYB.
AFIB. Key features. Rate can be normal, slow, or fast, but the rhythm is always irregular. Totally irregular. The baseline looks like squiggle lines. It's fibrillating, not contracting smoothly.
Irregular rhythm, squiggly baseline. What's the big danger with AFIB?
Clots. Huge risk. Because the atria aren't squeezing effectively, blood can pool, especially in a little pouch called the left atrial appendage. Clots form there, break off, and can travel to the brain, causing a stroke.
High stroke risk from the left atrial appendage, so treatment focuses on.
Do things. Controlling the rhythm or rate with antiarrhythmics like amiodarone or metoprolol, A&D preventing stroke with anticoagulants, think apixaban, clopidogrel, warfarin.
Anticoagulation is key. What if you want to cardiovert someone in AFIB?
You have to be careful about clots. Unless they've been properly anticoagulated for several weeks, you usually need a T first. That transesophageal echo we talked about? To look inside and make sure there isn't already a clot waiting to break loose when you shock them.
T before cardioversion unless they're safely anticoagulated. Makes sense. What about atrial flutter?
Flutter is different from fib. It's usually a regular rhythm, but instead of normal P waves, you see these characteristic sawtooth flutter waves. Multiple little peaks between the QRS complexes.
Regular rhythm, sawtooth waves, treatment.
Pretty similar to AFB, actually. Rate control, rhythm control, and definitely anticoagulation because the stroke risk is still significant.
Okay, so much for atrial rhythms. Now, the really dangerous ones. Ventricular rhythms, identified by?
A wide complex QRS, wider than 0.12 seconds, but often much wider, like 0.2 seconds.
Wide QRS ventricular. Let's start with PVCs, premature ventricular contractions.
Right. Early, wide beats that look different, often inverted. What causes them? Often electrolyte imbalances, specifically low potassium, K+, and low magnesium, Mg++. Caffeine can trigger them too.
Low K, low Mg, caffeine. Are all PVCs the same?
No. We look at their appearance. Unifocal means they all look alike, coming from one spot. Multifocal means they look different, coming from multiple spots. That's generally more concerning.
Unifocal versus multifocal. What about frequency?
If they happen in pairs, we call that a couplet. That's getting dangerous. And the most dangerous situation is if a PVC lands right on the T wave of the preceding beat. That's the R on T phenomenon.
R on T again. Why is that so bad with the PVC?
Same reason as with cardioversion. It can trigger a lethal ventricular rhythm like VTach or VFib. Extremely high risk.
So couplets and R on TPGCs are major warning signs. What are the actual lethal rhythms we need to recognize instantly?
Okay, the ones you absolutely have to know. Ventricular tachycardia, VTach, that's 3 or more PVCs in a row. The heart beats so fast there's no time to fill with blood. It can be with or without a pulse.
VTach. What else?
So that's the point. It's a specific type of VTach where the QRS complexes seem to twist around the baseline, switching direction, often related to medications or electrolyte issues.
Twisting VTach. Torsides. Next.
Ventricular fibrillation, VFib. This is chaotic electrical activity. No discernible QRS complexes at all. Just a wavy, quivering line. No contraction, no pulse. Fatal if not defibrillated immediately.
VFib, chaotic quiver. And the last one.
Asystole. Flatline. No electrical conduction, no heartbeat, nothing.
VTach, torsides, VFib, asystole. The lethal four. Got it. Quickly, what about heart blocks?
Heart blocks interfere with the signal getting from the atria to the ventricles, often caused by inflammation, like myocarditis or endocarditis, or sometimes ischemia or drugs.
How do we treat heart blocks?
If they're causing symptoms like bradycardia, treatment is similar. Atropine might help for lower-degree blocks, but if it's a high-degree block or sustained and symptomatic, they'll likely need a pacemaker.
Atropine or pacemaker like bradycardia.
Okay. Let's move to some major disease exemplars. Heart failure, HF. Right. Heart failure is basically when the heart just can't pump enough blood to meet the body's needs, can't perfuse tissues adequately.
What puts people at risk?
A lot of lifestyle factors and chronic conditions. Think obesity, being inactive, having chronic untreated hypertension, and definitely tobacco use.
Those are big ones. Now, the types of HF seem confusing. Diastolic versus systolic.
Okay, let's break it down. Diastolic HF is also called HFpEF, heart failure, with preserved ejection fraction. Think of the heart muscle as being thick and stiff.
Freaking stiff.
So
Right.
it doesn't relax or fill well during diastole, but the squeeze, the ejection fraction, might still be normal. It's often caused by hypertrophy from long-term high blood pressure.
Diastolic thick equals pore filling, preserved squeeze, EF.
Got it.
Now, systolic HF.
Systolic is HFrEF, heart failure with reduced ejection fraction. Here, think of the heart muscle as being stretched out and weak.
Stretched and weak.
So it fills okay, maybe even too much, but it contracts poorly. The squeeze is weak, so the ejection fraction is low. This is often caused by things like coronary artery disease, a previous heart attack, MI, or valve problems.
Systolic, stretched pore squeeze, reduced EF.
Up.
Okay, that helps. Now, symptoms based on left versus right side failure.
This follows the blood flow logically. Left-sided HF means blood backs up into the lungs, so symptoms are primarily respiratory.
Like what?
Pulmonary ED is the big one. You'll hear crackles, maybe wheezes. The patient will be tachypneic, short of breath. They might even cough up pink, frothy, blood-tinged sputum.
Left lungs,
Yeah.
respiratory distress. Okay, right-sided HF.
Right side failure means blood backs up into the systemic circulation the rest of the body.
So symptoms are more body-wide.
Exactly. Think heavy edema, especially in the legs and feet. Jugular venous distension, JVD in the neck, maybe ascites fluid buildup in the abdomen. Poor perfusion to the body overall.
Rest of body, systemic backup, edema, JVD. Okay. How do we manage HF?
Well, first, treat the underlying cause if possible. But a huge part is patient teaching. They need strict sodium and fluid restriction. Balancing rest with mild exercise is important too.
Sodium, fluid restriction, meds.
Medications are key. Diuretics help get rid of excess volume, reducing preload. ACE inhibitors are often used for maintenance. They reduce blood pressure and afterload, making it easier for the heart to pump.
Diuretics for volume preload, ACE inhibitors for pressure afterload.
Yeah.
What about digoxin? That one always seems high alert.
It absolutely is. Digoxin is a cardiac glycoside. It's a positive inotrope, meaning it increases contractility, makes the heart squeeze harder, but it also decreases the heart rate.
Increases squeeze, decreases rate. What's the critical check before giving it?
You must check the apical pulse for a full minute. Hold the dose if the heart rate is less than 60 BPM. Very important.
Hold vig of HR60.
And toxicity.
Classic signs. Patients might report yellow or green visual changes, seeing halos or an aura around lights. That's dig toxicity until proven otherwise.
Yellow-green halos. Digtox.
Right.
Antidote. Digibind. Digoxin immune fab. And one more practical point. Digoxin often comes in glass sample, so remember to use a filtered needle when drawing it up.
Filtered needle for amplis. Okay. Moving on to pulmonary embolisms, PEs.
PEs, usually caused by a deep vein thrombosis, DVT, a clot in the leg that breaks loose and travels to the lungs.
So prevention is key. How do we prevent DVTs?
Early ambulation after surgery is huge. Sequential compression devices, SCDs, elevating the legs. But critically, NO pillows directly behind the knees and tell patients not to cross their legs. Both can impede blood flow.
No pillows under knees, no crossing legs. Got it. What are the symptoms if a PE happens?
Sudden onset chest pain and shortness of breath are classic. If it's a large PE, you might see cyanosis or pallor, often described as being from the nipple lineup.
Chest pain, SOB, maybe cyanosis. What about lung sounds?
This is important. A PE is a perfusion problem, not usually an airway problem initially. So the patient likely does not exhibit adventitious lung sounds like crackles or wheezes. Their lungs might sound clear even though they're in distress.
Lungs might sound clear. Tricky. Diagnosis.
The quickest diagnostic test is usually a VQ scan, ventilation perfusion scan.
VQ scan. Treatment. Sounds like we need to bust that clot.
Exactly. It's appropriate. We use powerful thrombolytics like TPA, alteplase. But TPA has major risks.
What are the big contraindications for TPA? When can you absolutely not give it?
Okay, critical contraindications. Any recent trauma, especially a significant head injury within about 2 weeks, an uncontrolled hypertensive crisis.
Okay, recent trauma, head injury, bad HTN.
Also a recent GI bleed, again, within about 2 weeks. And interestingly, recent lumbar punctures.
Lumbar puncture. Why does that rule out TPA?
Because TPA doesn't just dissolve the target clot, it prevents clotting everywhere. That puncture site in the spinal canal could start bleeding massively, which would be catastrophic. So any potential bleeding site from recent procedures is a major concern. Usually about a 2-week window for those bleeds or procedures.
Got it. About 2 weeks for recent trauma, GI bleed, or LP. How do you give TPA safely?
Requires separate IV access. Nothing else should be infused through that line. Minimize any other punctures, no new IM injections, no new Foley catheters unless absolutely necessary. Patient needs strict bed rest.
A separate line, minimal punctures, bed rest. When do you stop it?
You must stop the infusion immediately and notify the provider if you see any signs of bleeding or hemorrhage. That could be obvious bleeding, or subtle signs like swelling at a site, a sudden drop in blood pressure, or blood showing up in urine or stool.
Stop TPA at any sign of bleeding. What if TPA is contraindicated?
Then we rely on anticoagulants like a heparin drip or enoxaparin injections to prevent the clot from getting bigger and allow the body to break it down slowly.
Okay, heparin enoxaparin if no TPA. Last big exemplar. Stroke?
2 main types. Hemorrhagic, which is bleeding in the brain, often from high blood pressure or trauma, and ischemic, which is a clot blocking blood flow.
What's the most common cause of ischemic stroke?
By far, AFib, that irregular heartbeat we talked about, leading cause of stroke-causing clots.
AFib again. Diagnosis, what's the first step?
Immediate CT scan without contrast. Absolutely crucial. You need to rule out a hemorrhagic stroke right away because the treatments are completely different. You cannot give clot busters if there's bleeding.
CT without contrast first. If it is an ischemic stroke, a clot.
Then TPA might be an option, but the time window is critical. It must be given within 3 hours of when the symptoms first started. Beyond that, the risk of causing a hemorrhage outweighs the potential benefit.
TPA for ischemic stroke, only within 3 hours of onset.
Okay.
Symptoms of stroke.
Usually unilateral, meaning one side of the body. You might see paralysis or weakness. Speech problems, called aphasia, could be receptive, difficulty understanding, expressive difficulty speaking, or global both.
Unilateral weakness, aphasia. What else?
Altered mental state confusion, disorientation, visual changes are common, like hemianopsia, where they lose half of their visual field, and dysphagia, difficulty swallowing.
Dysphagia sounds like a big risk.
Huge aspiration risk. Speech therapy ST absolutely must do a swallow evaluation before the patient eats or drinks anything.
Needs ST consult for dysphagia. Anything else critical about stroke symptoms?
Yes. Stroke symptoms can sometimes look a lot like hypoglycemia, low blood sugar, so you must check a blood glucose level immediately on anyone presenting with stroke-like symptoms.
Check blood glucose, rule out hypoglycemia. What's a TIA?
Transient ischemic attack. Basically, temporary stroke symptoms that resolve on their own, usually within minutes to hours. But a TIA is a major warning sign. It's considered a precursor to a full stroke. Needs urgent evaluation.
TIA warning sign. One last thing. Carotid endarterectomy.
That's surgery to remove plaque from the carotid artery in the neck.
Yeah.
Post-op, watch out for irritation to the baroreceptors located there. It can cause wild swings in blood pressure, both high and low. Needs careful monitoring.
Fluctuating BP after carotid surgery.
Okay.
Let's wrap up with hematology. Anemia.
Anemia is simply decreased red blood cells or hemoglobin, leading to reduced oxygen-carrying capacity.
Positive.
Lots of things. Nutritional deficiencies are big ones, lack of iron, vitamin B12, or folate. Genetic causes like sickle cell or thalassemia. Autoimmune issues where the body destroys its own RBCs, hemolytic anemia. Or kidney failure because the kidneys don't produce enough erythropoietin to stimulate RDC production.
Iron, B12, folate deficiency, genetics, autoimmune, kidney failure. Symptoms.
Symptoms basically look like decreased cardiac output or poor oxygenation. Skin might be pale, cold, maybe jaundiced, shortness of breath, weakness, dizziness. Blood pressure might be low. You might see palpitations or tachycardia as the heart tries to compensate, even chest pain.
Pale, cold, SOB, weak, dizzy, low BP, fast HR. Makes sense. Daily care focuses on
Hydration is always important. Good nutrition and supplementation if needed, iron pills, B12 shots, folate, protein. Because they're weak and dizzy, implement fall precautions. Tell them to change positions slowly and really prioritize rest and conserve energy. Medically, EPO alpha injections can stimulate RBC production if the cause is kidney-related.
hydration, nutrition, fall precautions, rest. EPO alpha. Got it. Hemophilia.
Hemophilia is genetic, carried on the X chromosome, so it's much more prevalent in men. It interferes with specific clotting factors.
What are the types?
Type A is a deficiency in factor 8. Type B is factor IX, factor 9 deficiency.
Factor 8 or 9. Does severity vary?
Yes, significantly. Severe cases might have spontaneous bleeding into joints or muscles with no obvious injury. Moderate cases usually bleed after trauma or surgery. Maybe occasional spontaneous bleeds. Mild cases might just be slow to clot after a significant injury.
How is it usually diagnosed?
For severe cases, the diagnosis often comes when the child starts moving around more. The average age for the first spontaneous joint bleed is around 18 months.
18 months for first joint bleed in severe cases. Treatment.
The main treatment is routine transfusion of the missing clotting factor they need, factor 8 or 9.
Factor replacement. What about managing bleeds when they happen?
Important patient teaching. No heat packs on bleeds or bruises. Heat causes vasodilation and increases bleeding. Use cold packs, but for less than 20 minutes at a time to avoid skin damage. Also, avoid wrapping things too tightly or putting excessive pressure on a bleeding limb. You could risk compartment syndrome.
No heat, cold 20 mins, avoid tight pressure. Okay, last one. Sickle cell disease, SCD.
Also genetic, X-linked recessive. causes defective hemoglobin S, which makes red blood cells sickle or become crescent-shaped, especially under stress like low oxygen or infection. These sickled cells are stiff and block blood flow.
That blockage causes the main problem, right? The crisis.
Exactly. The sickle cell crisis, also called a vaso-occlusive crisis, it's caused by widespread arterial occlusion from these sickled cells, leading to ischemia. It is extremely painful, and the pain can be anywhere in the body, often triggered by infection, highly recurrent for many patients.
Extreme pain from occlusion. That's acute chest syndrome, ACS.
This is a very serious, often fatal complication. It's basically micro-occlusions happening in the blood vessels of the lungs. Symptoms look like pneumonia, chest pain, shortness of breath, cough, fever. It's a common cause of death in SCD patients, accounts for maybe 25% of deaths.
Chest pain, SOB, cough, fever, ACS, lung sounds.
Similar to PE, because it's primarily a vascular occlusion problem in the lungs, ACS likely does not present with adventitious lung sounds initially. Another tricky one where clear lungs don't rule out serious pathology.
Clear lungs again.
Okay.
Treatment for SCD.
One key medication is hydroxyurea. It helps by increasing the production of hemoglobin F, fetal hemoglobin, which doesn't sickle as easily, reducing the frequency of crises.
Hydroxyurea increases HbF.
Yeah.
Side effects.
Significant ones. It causes immunosuppression, making patients much more vulnerable to infections. It can also be toxic to the liver and kidneys, hepatonephrotoxic, requires careful monitoring.
Immunosuppression, liver, kidney toxicity. What about the pain during a crisis?
The pain is severe. Narcotic analgesics are essential, often morphine, sometimes via a PCA, patient-controlled analgesia pump.
Narcotics for pain. Downsides.
Big ones. Respiratory depression is always a risk with opioids. Addiction potential with long-term use. And they cause significant constipation, so prophylactic stool softeners are almost always needed.
Respiratory depression, addiction, constipation, use stool softeners. How can patients prevent crises?
Staying well hydrated is crucial. Preventing infections is key. Good hygiene, avoiding sick contacts, and vaccination is very important.
Vaccination. Any caveats?
Yes, a critical one. If the patient is taking hydroxyurea and is therefore immunosuppressed, they should not receive any live vaccines, like MMR or varicella. Inactivated vaccines are generally okay.
No live vaccines if on hydroxyurea immunosuppressed.
Got it. Phew. Okay, I think we've hit the absolute critical path. We raced from basic perfusion mechanics and essential labs through interpreting those dangerous EKGs, and then tied it into managing complex conditions like heart failure, PEs, strokes, and these key hematologic disorders. It all ties together, you know? The state of the blood, its components, its ability to clot or not clot directly impacts how the heart functions, how oxygen gets delivered, and ultimately how the brain and every other organ survives.
That interconnectedness is exactly it. And that's the mindset you need for the exam. Think about the sheer number of critical checkpoints we just hammered home, knowing troponin isn't just a number but a trend. Making sure that cardioversion shock hits the R wave perfectly. Remembering to check blood glucose before assuming stroke. It really drives home that every single clinical detail, every assessment, every intervention is potentially a life or death calculation. You got this material, good luck on the exam.